I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Woolfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today we're talking about leiomyosarcoma, not to be confused with leiomyomas, which are also known as benign uterine fibroids. We covered fibroids in last week's episode, so if you're looking for an update on fibroids, check it out. So what exactly is a leiomyosarcoma?
Leiomyosarcoma is a rare and aggressive form of cancer that arises from the smooth muscle tissue in the uterus. It's a type of uterine sarcoma. We'll focus mainly on leiomyosarcoma today because it is the most common of the uterine sarcomas, but it is important to know a little bit about the other types of uterine sarcoma. Now, we've all heard of endometrial cancer, which arises from the cells of the endometrial lining of the uterus. Well, uterine sarcomas arise from the myometrium, or the connective tissue element of the endometrium. Uterine sarcomas are much less common than endometrial carcinomas, accounting for less than 10% of uterine malignancies. They are also much more aggressive and convey a poorer prognosis than endometrial carcinoma.
Thankfully, uterine sarcomas are extremely rare. One study reported the incidence of uterine sarcoma to be 2.8 per 100,000 person years among females aged 30 to 79. Another study reported data showing that the prevalence of unexpected leiomyosarcoma at the time of surgery for presumed symptomatic fibroids ranged from less than 1 to 13 per 10,000 surgeries. The mean age diagnosis is approximately 60 years old, and most sarcomas occur in patients over the age of 40, although they have been diagnosed in patients as young as 20. Black patients have double the incidence of leiomyosarcoma compared to white patients, but this doesn't apply to other types of uterine sarcoma.
The risk factors for uterine sarcomas include ethnicity, only for leiomyosarcoma, increasing age and postmenopausal status, long-term tamoxifen use, pelvic radiation, and hereditary conditions. Now, we know that tamoxifen is associated with endometrial cancer due to its pro-estrogenic effects on endometrial cells, which can then lead to endometrial hyperplasia and endometrial cancer. But did you know that tamoxifen is also associated with an increased risk of uterine sarcoma? The absolute risk of this happening is actually very small. We're talking about 1 in 10,000. If sarcoma does develop, it usually presents 2 to 5 years after starting tamoxifen and tends to be quite advanced at the time of diagnosis. Pelvic radiation has typically been a risk factor for carcinosarcoma, although as we'll learn soon, carcinosarcoma is now classified as adenocarcinoma rather than a sarcoma. Our hereditary conditions include HLRCC and childhood retinoblastoma. HLRCC stands for hereditary leiomyomatosis and renal cell carcinoma and is a rare autosomal dominant mutation in the fumarate hydratase gene. It causes cutaneous and uterine fibroids and an aggressive form of papillary renal cancer. Most patients with this condition will develop multiple fibroids at an early age rather than the general population. However, in some patients, they can develop uterine or even cutaneous leiomyosarcoma. Even in this population group, though, the incidence of leiomyosarcoma is very low. Long-term survivors of hereditary childhood retinoblastoma are also at a higher than average risk for sarcomas.
Wait, you forgot uterine fibroids. Surely having a leiomyoma increases the risk of developing leiomyosarcoma.
Well, actually, that's not true. We used to think that leiomyosarcoma were just benign fibroids that became cancerous, and in fact, previously, patients with fibroids were warned about the risk of malignant transformation of their fibroids. Leiomyosarcomas do not typically develop from benign fibroids. They actually appear to arise independently and have much more complex karyotypes compared to fibroids. Now, there are always exceptions to the rule, and there are a few studies that suggest that some fibroids might progress to sarcoma. However, this is much, much, much less common than previously thought. And for a disease that is already incredibly rare, the chances of it arising from a benign fibroid are even more unlikely. So when we discuss risk factors for leiomyosarcoma, fibroids are not considered to be a precursor and are therefore not a risk factor.
So interesting. Okay. So how do we know if somebody has a uterine sarcoma? How do these tumours normally present?
Well, the most common way for a uterine sarcoma to be diagnosed is actually after it's been removed. Most uterine sarcomas are diagnosed on histological examination after myomectomy or hysterectomy for what was thought to be a uterine fibroid. In some cases, a uterine sarcoma might be diagnosed preoperatively based on endometrial sampling. In most cases, the diagnosis isn't very obvious. Most patients will present with signs and symptoms that are also very typical for uterine fibroids. These include abnormal uterine bleeding, pelvic pain or pressure, abdominal distension, or a uterine mass. Some patients describe a foul-smelling discharge, and some may even be asymptomatic, making it even harder to make the diagnosis. Examination findings are typically the same as that for fibroids.
So if uterine sarcomas present in the same way as fibroids, how can we tell the difference between a leiomyoma and a leiomyosarcoma?
Yep, it's such a difficult clinical question. I mean, most of the time, if it walks like a duck and talks like a duck, then it's probably a fibroid, right? Since fibroids are ridiculously common and uterine sarcomas are extremely rare, then the most likely diagnosis is going to be a benign fibroid. Historically, it wasn't that important to distinguish between a benign fibroid and a uterine sarcoma, since all patients with a uterine mass were treated with hysterectomy. If a uterine sarcoma happened to be identified postoperatively, whilst the treatment may have been incomplete, it didn't worsen the prognosis. Nowadays, we have so many different ways of treating uterine fibroids that don't involve hysterectomy, and so distinguishing between a benign fibroid and a uterine sarcoma is much more important.
Exactly. Treatment for fibroids now includes medications, MR-guided focused ultrasound, and conservative surgeries like uterine artery embolization. These treatments don't provide specimens for pathologic examination, meaning the diagnosis of a malignant neoplasm can be missed. Other treatments like a myomectomy or a hysterectomy with morcellation might even cause dissemination of an undiagnosed sarcoma, which can often upstage the malignancy. Because of this, it's important that we try and work out whether the mass we're dealing with is likely a benign fibroid or something more sinister like a uterine sarcoma. Unfortunately, though, there is no reliable way to determine if a fibroid might be a leiomyosarcoma prior to surgical removal and review by the pathologist.
Well, that's unhelpful. So what are we supposed to do then? Should we just be offering hysterectomies to every single patient with uterine fibroids, just in case they have a sarcoma?
Definitely not. Uterine fibroids are really common, affecting up to 80% of women, whereas uterine sarcoma is incredibly rare, affecting less than 0.2% of these women. If we were to recommend hysterectomy to every single woman with a uterine mass, we would be doing a lot of unnecessary surgeries. In fact, this would actually lead to an increase in harm since the risk of sarcoma is much lower than the risk of severe complications associated with hysterectomy. The goal is to avoid an unnecessary surgery for the purpose of excluding a very rare sarcoma and to give women at low risk of sarcoma the option of minimally invasive approaches, all while detecting sarcomas in those at increased risk.
Okay, so we shouldn't jump straight into recommending a hysterectomy in patients with fibroids purely to exclude a uterine sarcoma. But if we suspect a uterine sarcoma, then we should be recommending hysterectomy without disrupting the mass. But there's no clear way for us to tell if a fibroid is actually a uterine sarcoma. Right. Well, this is very confusing. What am I actually supposed to do in practice?
Well, while we can't tell for sure if a suspected fibroid is actually a uterine sarcoma, there are some findings that might raise our index of suspicion. Firstly, there are some suspicious features on imaging. On a pelvic ultrasound, features that are suggestive of sarcoma include mixed echogenic and poor echogenic parts, central necrosis, irregular tumour borders, colour Doppler findings of irregular vessel distribution, low impedance to flow, and high peak systolic velocity. Again, however, many of these characteristics may also be found in benign fibroids, so the positive predictive value of ultrasound in diagnosing sarcoma is actually quite low.
MRI with gadolinium contrast is usually used if the ultrasound suggests the possibility of a leiomyosarcoma. MRIs are quite good at identifying typical benign fibroids, and this test has a very good negative predictive value. Typical features of leiomyosarcoma on MRI include solitary uterine mass arising from the myometrium with poorly circumscribed or infiltrating irregular borders, absence of calcifications or presence of necrosis, presence of intralesional hemorrhage, although this is a pretty weak association, and the presence of abnormal lymph nodes. Unfortunately, a PET or CT scan is not particularly helpful.
With bloods, a small case series have actually reported elevated CA125 and a subtype of LDH, isoenzyme type 3. So if a patient has a particularly high LDH, you might be a little bit more suspicious for uterine sarcoma. What about rapidly growing masses? Although there's not really any evidence for surveillance for fibroids, I know that some patients will get serial scans to make sure the fibroids remain stable and they aren't growing. Is this because we're looking for uterine sarcomas?
So it's interesting you mention that because we used to be taught that rapid growth of a uterine mass is a sign of a potential uterine sarcoma. Although it seems that most patients with a rapidly enlarging uterus or uterine mass actually don't have a sarcoma. Benign fibroids will naturally grow and shrink, and they can do so at differing rates with the same patient. Research on normal fibroids shows that growth of up to 140% can occur within 6 months. It's also possible that a sarcoma could remain indolent for a long period of time and only start growing once a more aggressive phase of disease is entered. So monitoring for stability of fibroid size is also pretty unhelpful. So although everyone tends to worry when a patient is referred with a rapidly enlarging uterus or a uterine mass, chances are they don't have a sarcoma. The caveat to this is the postmenopausal woman with a new uterine mass or a growing mass.
Yeah, exactly. We mentioned previously that fibroids have estrogen and progesterone receptors, and so they are susceptible to hormonal fluctuations. Well, in menopause, the levels of estrogen and progesterone naturally decline, and thus fibroids actually tend to shrink. Now, postmenopausal women on hormone replacement therapy might actually notice a little bit of growth in their fibroids, and this can be normal. If you are worried, you could always stop the MHT to check for regression or do an endometrial biopsy.
Now, just on endometrial biopsy, although we do recommend endometrial sampling in women of whom sarcoma is suspected or prior to potential morcellation, it's important to know the limitations of that test. Endometrial sampling prior to surgery has a low predictive value in diagnosing uterine sarcomas. Sadly, it's not 100% sensitive and only yields a preoperative diagnosis in 33 to 68% of patients with a uterine sarcoma. Now, you might be thinking, well, why don't we just do an ultrasound-guided needle biopsy of the mass? Unfortunately, this is not typically performed. The problem is that accurate diagnosis would require sampling of multiple sites of the mass, and there's a possibility that simply by doing this, you might cause spillage of malignant cells into the peritoneal cavity and spread the disease.
Okay, so far we've established that there is really no reliable way of diagnosing a uterine sarcoma, but we should consider the diagnosis in postmenopausal women with a new or rapidly growing mass. Is there anyone else we should be suspicious of?
Postmenopausal women with presumed fibroids who have symptoms that are bothersome enough to consider a hysterectomy should also be considered as at risk of sarcoma. However, the actual incidence of this is still only 0.2%. And then in premenopausal patients with presumed fibroids, we should consider a uterine sarcoma if the bleeding is disproportionate to the uterine size and the patient reports significant pain.
So what do we actually do with this information? We've listed a few things that might make us more suspicious of a uterine sarcoma, but we've also mentioned that there's no accurate way to definitively diagnose our sarcoma short of histological examination.
Well, like we said before, you can always consider endometrial sampling, understanding that the sensitivity for that isn't perfect. Our next consideration would be in how we manage patients who might be at an increased risk of sarcoma. Premenopausal patients who have suspicious endometrial sampling, an MRI that strongly suggests sarcoma, or symptoms and imaging findings consistent with metastatic malignancy should obviously be referred for gynae-oncology for a hysterectomy. Postmenopausal patients who are undergoing hysterectomy for presumed symptomatic fibroids don't need referral to gynae-oncology, but you should be aware of the possibility of undiagnosed malignancy. For these patients, you would ideally avoid morcellation. In any patient, if the plan for uterus or fibroid removal includes morcellation, then endometrial sampling should be performed first, and a containment bag system should always be used.
Okay, so before we move on to staging and management of leiomyosarcoma, let's summarize what we've learned so far. Uterine sarcomas are malignant tumours that arise from the myometrium or connective tissue of the uterus. They are rare, occurring in 2.8 per 100,000 women years. The mean age at diagnosis is approximately 60 years old, and most sarcomas occur in patients over 40.
Risk factors for uterine sarcoma include Black ethnicity, but only for leiomyosarcoma, increasing age and postmenopausal status, long-term tamoxifen use over 5 years, pelvic radiation, and hereditary conditions like HLRCC and childhood retinoblastoma.
Fibroids are not a risk factor for uterine sarcoma, and fibroids do not undergo malignant transformation to become sarcomas. Instead, uterine sarcomas develop independently. The diagnosis is usually made on histopathological examination after a myomectomy or hysterectomy. Otherwise, it's really difficult to discern between a fibroid and a uterine sarcoma based on history, exam, and pelvic ultrasound findings.
Uterine sarcomas present in a similar way to uterine fibroids with abnormal uterine bleeding, pelvic pain or pressure, abdominal distension, or a uterine mass. Examination is again similar, and they can also look like fibroids on imaging. Ways to differentiate a benign fibroid from a uterine sarcoma include findings on the history, findings on the ultrasound, findings on the MRI, and abnormal endometrial biopsy.
Features in the history include postmenopausal patient with new or rapidly growing mass, postmenopausal patient with symptoms sufficient enough to warrant hysterectomy, premenopausal patient with heavy bleeding out of proportion to the uterine size.
Findings on ultrasound include mixed echogenic and poor echogenic parts, central necrosis, irregular tumour borders, colour Doppler findings of irregular vessel distribution, low impedance to flow, and high peak systolic velocity.
Findings on MRI include a solitary uterine mass arising from the myometrium with poorly circumscribed or infiltrating irregular borders, absence of calcifications or presence of necrosis, presence of intralesional hemorrhage, and abnormal lymph nodes or evidence of metastatic disease.
Rapid growth of a fibroid or solitary large uterine mass are not considered to be features of uterine sarcoma.
Okay, so now we know the basics. Let's move on to the diagnosis and management of uterine sarcoma.
Now, assuming that most uterine sarcomas are diagnosed postoperatively, let's go into the histopathological findings. The classic features of a sarcoma are cellular atypia, mitoses, and coagulative necrosis. Together, these three criteria are known as the Stanford criteria. Uterine sarcomas are also classified as homologous or heterologous. Homologous sarcomas only contain elements normally found in uterine tissues, like endometrial stroma, smooth muscle, vascular tissue, and fibroid tissue. Homologous sarcomas are the most common type and include endometrial stromal sarcoma and leiomyosarcoma. Heterologous sarcomas contain non-native elements like skeletal muscle, cartilage, bone, and fat, and include uterine rhabdomyosarcoma and uterine liposarcoma. Histological grade deeply impacts on prognosis and clinical behaviour. While high-grade endometrial stromal sarcomas are generally highly aggressive, low-grade endometrial stromal sarcomas have an indolent behaviour. Leiomyosarcomas are highly aggressive and tend to have a very high recurrence rate.
Once a uterine sarcoma is diagnosed, we need to arrange staging investigations and refer to gynecology-oncology. Obviously, if you have any suspicion that a patient might have a uterine sarcoma, you should arrange these investigations and complete the GONC referral before undergoing surgical management. Staging investigations include a CT chest abdo-pelvis, an MRI, or a PET scan, and each gynecology-oncology department will typically have a preferred line of imaging they want you to order. 33% of patients with newly diagnosed leiomyosarcoma will have distant metastases, most commonly involving the liver, lung, or upper abdomen. Therefore, all patients should undergo imaging to rule out metastases.
Uterine sarcomas are staged based on the FIGO 2017 classification system. Stage 1 is limited to the uterus, with stage 1A being less than 5 centimetres and stage 1B being greater than 5 centimetres. Stage 2 extends beyond the uterus but within the pelvis. Stage 3 extends to abdominal tissues, with 3C being nodal involvement. And stage 4 includes spread to the bladder and rectum or distant metastases. Most uterine sarcomas will be diagnosed at stage 1. In one series of over 1,000 cases of uterine sarcoma, the distribution of stages at presentation was 60% stage 1, 16% stages 2 and 3, and 22% stage 4. Interestingly, staging does not predict prognosis for overall survival.
When talking about staging, it's always important to know how cancers are spread and which organs they usually metastasize to. For uterine sarcomas, they spread through the bloodstream and commonly to the lungs, liver, abdomen, and pelvis. Bone and brain metastases are less common, but nevertheless they can occur.
So once we've diagnosed and staged our uterine sarcoma, what's next? What's our management plan for these patients?
As with all malignancies, our management options include surgery, chemotherapy, and radiation therapy. The gold standard for management of uterine sarcomas is surgical excision of the tumour. We aim for complete removal of the tumour without fragmentation and with negative surgical margins. This typically means a hysterectomy and a bilateral salpingo-oophorectomy. Morcellation should absolutely be avoided. In premenopausal patients, it can be okay to spare the ovaries as this doesn't seem to affect survival rates. Systematic pelvic and para-aortic lymphadenectomy is not recommended. As we mentioned before, uterine sarcoma spreads through the bloodstream, and so we really only need to resect the lymph nodes when preoperative imaging or intraop findings suggest lymph node metastases. In patients in whom complete cytoreduction is not possible, it might be preferable to treat with chemoradiation therapy.
What about the situation where you've already done a hysterectomy and you only found out about the uterine sarcoma postoperatively? Do you need to go back in and do a staging surgery?
In general, there's no need for a second staging procedure unless the primary surgery was a subtotal hysterectomy or a myomectomy. In these patients, surgical resection should be repeated with a hysterectomy or removal of the cervix. The other consideration for a repeat procedure would be if you performed morcellation before realizing the patient had a uterine sarcoma. In these situations, surgical exploration could be performed to ensure any residual peritoneal disease is resected. The reason we try to avoid morcellation is because it can often result in a spread of the malignant disease through the abdominal cavity.
And what about the situation where you've identified possible sarcoma preoperatively, but there appears to be loco-regional spread?
If leiomyosarcoma is suspected with disease extending beyond the uterus, then surgery is controversial, and we recommend guidance from your local GONC team. If complete resection of disease is possible, then do surgical cytoreduction, but only if you can get to zero residual disease. If the gynae-oncologists are not able to achieve complete resection, then there's no benefit to surgery, and instead it's recommended the patient goes straight to chemotherapy. The one exception to that would be if the patient opts for a TLH for palliation because they're experiencing significant symptoms like pain or vaginal bleeding.
So let's go into the role of adjuvant therapy for uterine sarcoma. So let's go into the role of adjuvant therapy for uterine sarcomas. Firstly, it's important to note that there is no clear evidence that the administration of adjuvant chemotherapy is associated with improved survival in either leiomyosarcoma or endometrial stromal sarcoma. Although there are a few phase 2 studies that have suggested that adjuvant chemotherapy might provide a survival benefit for leiomyosarcoma compared to observation alone. Given the poor prognosis of leiomyosarcoma, adjuvant chemotherapy is still typically offered, and the choice of medication should be made by a multidisciplinary tumour board and discussed with the patient. Typically, anthracyclines are the backbone of chemotherapy. For high-grade endometrial stromal carcinomas, adjuvant chemotherapy is not the standard of care and is definitely not recommended for stage 1 disease. For patients with higher stage disease, there is quite a poor prognosis, and despite a lack of evidence, adjuvant chemotherapy could be considered.
Adjuvant radiotherapy has also not demonstrated a statistically significant increase in survival versus observation alone in early-stage, high-grade uterine sarcomas, and therefore its use is not considered to be standard of care. Despite this, adjuvant radiotherapy could be considered in selected patients with risk factors for recurrence, such as cervical, parametrial, or serosal involvement, or incomplete resection after discussion with the patient.
Now, obviously the point of adjuvant therapy is to prevent recurrence and increase survival, and the decision of when to use chemoradiation therapy and when to avoid it can be quite complex. This is where the multidisciplinary team comes in, assessing each patient and making recommendations to help benefit that person. So, let's talk about recurrence. What should we do with recurrent uterine sarcoma?
The principles of management of recurrent sarcoma are again very similar to the initial management of uterine sarcoma: arrange staging investigations and refer to gynae-oncology. The management of recurrences themselves, though, depends on whether we're dealing with a leiomyosarcoma or an endometrial stromal sarcoma. There is good evidence that complete surgical resection of recurrent metastatic disease can increase survival in selected cases of leiomyosarcoma. The goal is to get to zero residual, and in these cases, the patient may not have any further benefit from postoperative chemoradiation therapy. In high-grade endometrial stromal sarcoma, resection of metastases is not usually considered due to the aggressive clinical course, although you could consider surgical excision of local recurrence if you are able to remove it all. In these patients, postoperative radiation therapy would typically be recommended.
Okay, to summarise our management. The goals of management is surgical resection with the aim to achieve zero residual disease. There is limited evidence for chemotherapy and radiation therapy in improving survival, but adjuvant therapy may be considered in some patients. Recurrent disease is best treated with surgical excision for leiomyosarcoma, but for high-grade endometrial stromal cell sarcoma, resection should only be considered for local recurrence, not metastatic disease. What about molecular markers? Is there any role for hormonal or targeted molecular treatments?
In terms of molecular markers, there are no chromosomal translocations or characteristic gene mutations associated with uterine sarcomas. Instead, there are commonly multiple chromosomal abnormalities leading to chromothripsis. Chromothripsis is a genetic phenomenon where up to hundreds of clustered chromosomal rearrangements can arise in a single catastrophic event. This means they're not therapeutically actionable, and there's no current role for immunotherapy agents. Watch this space, though, because researchers are always coming up with new potential targets for therapy.
Chromothripsis, a new trivia word.
Obviously, these uterine sarcomas can be quite aggressive and are associated with a high rate of recurrence. So how do we go about monitoring these patients to check for recurrence?
The recommended surveillance for uterine sarcoma includes a physical exam, chest x-ray and pelvic ultrasound every 3 to 4 months for 3 years, then every 6 to 12 months for the next 2 years.
And what's the prognosis like for patients with uterine sarcoma?
Unfortunately, uterine sarcomas are quite an aggressive malignancy with a really poor prognosis regardless of the stage. There's also no clear prognostic information that we can use to help manage patients' expectations. There is a nomogram that incorporates patient age, tumour size, grade, local extension, distant mets, and mitotic rate to help predict the 5-year survival. This appears to be more accurate than 5-year survival based on stage alone, but conversations about prognosis are probably best left to the multidisciplinary team as there are so many contributing factors.
Okay, time for another summary. The diagnosis of uterine sarcoma is based upon histological examination of a tissue sample. The diagnosis is often unexpected and made upon routine pathology examination after myomectomy or hysterectomy performed because of a presumed leiomyoma. Unfortunately, there's no reliable way to distinguish a leiomyoma from a leiomyosarcoma prior to removal and review by a pathologist. Staging is done according to the 2017 FIGO classification system, and we'll post a photo of this table on our summary slides later this week. For a preoperative diagnosis, a total hysterectomy is indicated for patients after a CT chest abdo-pelvis that confirms the disease confined to the uterus. Bilateral salpingo-oophorectomy is recommended at the time for perimenopausal and postmenopausal patients. For patients with disease beyond the uterus but confined to the peritoneal cavity, perform surgical cytoreduction. Pelvic lymphadenectomy is only reserved for patients with palpably enlarged pelvic nodes intraoperatively.
In a postoperative diagnosis, no second procedure is required unless the diagnostic operation was a myomectomy or supracervical hysterectomy. If the tumour is limited to the body of the uterus, adjuvant chemotherapy and radiation therapy have no role in improving survival outcomes. Observation is better with the patient coming in for a physical exam, chest x-ray and pelvic ultrasound every 3 to 4 months for 3 years, then every 6 to 12 months for the next 2 years.
Remember, this is a rare but aggressive tumour, and it's important to think of them when you're planning for surgery for suspected fibroids.
And that brings us to the end of this week's episode on the Uterine Sound. Thanks for listening. You can find our summary slides on Instagram later in the week. If you have any comments, feedback, or want to fact check us, please reach out on our email, theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound and our website, www.theuterinesound.com.